talk a little bit more about runner's knee, ITB, patellofemoral pain syndrome. Yeah. So one of the things we need to do is a functional assessment on somebody. So you get them to do a single leg squat. You don't really want them to be pushing their knee over their toes necessarily, but if that's what they do functionally, then you start to understand where they're at. So you need to look at it side on as well and see what their control on their single leg squat is like. Because you want to be looking, they need to do at least 5, because you're looking at whether there's much rock and roll around the foot and ankle. You need to see whether the knee's got a valgus presentation or not. Females will always be slightly more valgus than men, so you've got to put that into your consideration. But if you get someone that's got pain on the outside their knee, hurts more when they walk downstairs than it does when they walk upstairs, it hurts when they run, not at other times, you're starting to think ITB friction syndrome, right? So get them to do 5 single leg squats, and if over the time their knee starts to do this, then you know there's a lack of control. However, if they're really, really tight, and you've done your Ober's test as shown in the other video, and you realise that their knee is really, really tight, but they've still got a half decent single leg squat, why don't you do the release, shown in the ITB release video that we just did, and then get them to do a single leg squat again. And I think you'll find that their control will be off right from the outset. Get them to do 5, redo the Ober's test, and you'll see that all the tension that you just released has come back in. So, you've now proven to your client that they've got a weakness around the glute, they've got a functional weakness, so maybe the foot and ankle are unstable as well, but you've also shown them that when you release it, which is possible, which will take away the symptoms, without the strength there, they've lost control of their knee. So that helps them to understand the benefit of them doing their strengthening exercises, but also the benefit of them coming for a few sessions to get it fixed. Now, one of the key factors is, where can they get control? So I work on a mini single leg squat. So I get people for the first week doing as many single leg squats as they can, but on a very, very small range. Learn to do the technique correctly in an inner range. Then as they start to go through their therapy, you can start to build them up, dropping about an inch every week. So by the time they get to the crucial 65-degree knee bend, which is what you need to be functional when you're running, then they should have good control. They've got to do so many reps, especially if they're training for a marathon. They might be doing 40 to 50,000 steps across that marathon. How do you possibly train someone to do 40 to 50,000? Would be half that, wouldn't it? 25,000 reps. It's impossible. So you just have to build the strength up as much as you can, both with functional single leg squat. You need to get them to do a good clam without the hip rolling back, and really good abduction, but I like just to put a little bit of little toe rotation at the top without the hip sinking back. That's important. So they're starting to work TFL a little bit like that. Good things are put them into a really good hip flexor stretch, and my favourite, which is glute activation. And if you get them to do that with some good core work, not just planks but really good core work, then I think you've got a very robust way of getting that person ready for their run, taking away their ITB friction syndrome, and it's a very staged process which, if you are quite motivated to see the person right the way through their treatment package and not have someone go, it doesn't hurt now so I'm going to stop, you can show them very definable objective measures to why they're not quite ready to stop therapy and just go ahead and be injury free.